So psoriasis, a chronic systemic inflammatory skin disease, manifests itself on many parts of the skin. And different clinical presentation or shades could be seen in different situations, such as when mimicking or in association with other diseases. I would like to share with you some situation where the clinical diagnosis is not obvious because of the different shades of the disease, maybe less than 50, but we should be aware of them. This boy was referred for erythematous scaly plaque on the elbows and knees with a specific distribution on the face. It started 4 years ago and partially improved in summer. As we see, we have a combination of clinical features of atopic dermatitis and psoriasis. In fact, psoriasis in children may be confused clinically with atopic dermatitis, and indeed, the two conditions may coexist. So to distinguish this disease when there is no overlap is critical for correct and timely diagnosis and optimal treatment. A 45-year-old man referred to us for itchy and erythematous scaly lesion on the hands, feet, knees, elbows, which started 3 months ago. Patient was known to have some flares of eczema. Antihistaminics and topical corticosteroid use did not improve, obviously, the condition. 2 biopsies were performed and 2 different results were received. Histopathological feature of psoriasis in one and feature of spongitic dermatitis in the second. So we did not perform patch test as the flare did not calm down. The question was that psoriasis, eczema, or coexistent psoriasis and eczema, or allergic contact dermatitis in sensitized psoriasis? Our question is still open and unanswered, but our patient was improved with methotrexate. A 20-year-old girl seen with psoriasis-formed papillosquamous, sharply defined lesions are distributed on the face, neck, trunk with slight delicate scaling. There was neither atrophy nor hyperpigmentation. Hyperkeratotic lesions are on the soles and palms. The eruption did not occur after solar exposure. The disease started 2 months earlier. Laboratory examination, histopathology for the scalp, psoriasis, on the face, lupus. Immunofluorescence of the skin, negative. ANA, negative. No other symptom. So one should raise the question, was that psoriasis, lupus, subcutaneous lupus, or coexisted psoriasis and lupus? It was almost the latter condition as it has been reported, and it represents a therapeutic challenge because medication commonly used for lupus are known to make psoriasis worse. Likewise, UV phototherapy is generally avoided in lupus. Psoriasis and vitiligo. Psoriasis and vitiligo are common dermatologic conditions with underlying autoimmune etiology. There are few reports of concomitant and co-localized disease, but no proper relationship has been found between these two diseases. Several theories have been proposed to explain this representation, but it seems that the two diseases would have a common ground, which is a low level of vitamin D. That's why some treatment, such as narrowband UVB, is efficient in psoriasis and in some cases of vitiligo. Inverse psoriasis is a rare form of psoriasis that affects between 3 to 7% of psoriasis patients, especially in elderly. Its appearance and distribution in the flexural skin folds makes it a difficult disease to diagnose. It is often confused with tinea curl. Psoriasis and seborrheic dermatitis are both chronic erythematous scaly dermatoses that can involve the scalp and the face. So it may be difficult to differentiate these diseases when there is isolated scalp involvement. Dermoscopy seems to be valuable for clinical diagnosis and different diagnosis of scalp psoriasis and seborrheic dermatitis. Psoriasis and anti-TNF-alpha. Psoriasiform and eczematous lesion induced by anti-TNF-alpha have been widely described in the literature. However, various names can be found to define this eruption: new onset psoriasis, paradoxical psoriasis, or psoriasiform eruption, leading to a confusion related to the cause, and moreover, the same patient can develop skin lesion with clinical and pathological feature of either psoriasiform and eczematiform lesions, adding more confusion. On this photo, this student looks so similar and so may be related. In fact, they are not. They don't have the same family name either as these cases. This boy, with scaly patches on the scalp with normal hair, this feature fit with the diagnosis of psoriasis. But if we look on the side of the scalp, there is a patch without hair. It was tinea. So he had psoriasis and tinea. Two different patients with thick scales on the elbows and the sacral area. It was crusted scabies and psoriasis. Two other patients with scales on the elbows. It was psoriasis and scabies. Nail psoriasis and onychomycosis, widely reported and often confused. They are onychomycosis and psoriasis. So this patient with two big toes on the same foot had both onychomycosis and psoriasis. Leukonychia, rising from the proximal fold in two patients. It was psoriasis and onychomycosis. Erythematous, scaly lesion on the elbows in three different patients. Leishmania and psoriasis. Two scaly lesions on the elbows. It was tinea and psoriasis. So here I am focusing on the elbows with this similar lesion. It was eczema, psoriasis, and eczema. Which one is psoriasis here? Erythema with scale on the left. There was tinea pedis and psoriasis. Plantar keratoderma. It was palmoplantar keratoderma and psoriasis. Palmoplantar keratoderma and psoriasis. Psoriasis or not, it was keratoderma, palmoplantar keratoderma. Which one? It was psoriasis and frictional keratoderma. This one, it's very so confused. It was scabies and psoriasis. So, for the take-home message, many mistakes are made by not looking than by not knowing. And thank you very much.